Hello, I'm Elena Hernandez,
I'm Mackenzie Patrick.
I'm Elise Baer.
I'm Mackenzie Summers.
and this is our presentation on static and dynamic posture. For our health risk assessment, we use the ACSM health history form, and you can open that link to get the full file, or otherwise we're just going to go over the main points of health screening, health and fitness goals, family history, occupation, and past injuries. He had a normal health history with nothing abnormal other than asthma and difficulty breathing at times. He also characterized his lifestyle as sedentary, as he was sitting 8 to 10 hours daily. We also asked about his health and fitness goals, with some of his goals being to improve his cardiovascular fitness, muscular size, and strength. He also played sports, specifically wrestling and jiu-jitsu, and he currently weightlifts. Next, we asked about his family history, of which he has a family history of hypertension, high cholesterol, diabetes, and some other diseases. Mainly, we wanted to ask about his health history information, and that's going to be regarding his past injury and occupations. His past injuries included a left shoulder dislocation, left hip strain, right index finger dislocation, and left ankle sprain. In addition, his occupation is a leasing agent, where he sits 8 to 10 hours daily and wears dress shoes. Along with that, he's also a student at GCU. Next, we did a static posture assessment. When looking at the anterior side, we could tell that the left scapula was elevated by identifying the chromium process. An article I read that was made in 2024 also noted that a shoulder dislocation can lead to shoulder dysfunction and scapular dyskinesis, so that can also probably lead to why his left scapula is elevated after his shoulder dislocation. The shoulder dislocation also wasn't properly rehabbed, which can contribute even more to that improper scapular positioning. As for his lower body, he does have foot pronation, leading to bilaterally collapsed arches. His feet are also externally rotated, with his right foot being more prominent in that external rotation. His tibia and femur are externally rotated as a result of his feet being externally rotated, but they are in line with his tibia is still in line with his second and third metatarsals. There's also elevation of the right anterior superior iliac spine as compared to the left side. From the lateral view, he did have a normal kyphotic curve of his thoracic spine and normal elbow extension and flexion, although they are a little bit in front of him. What we did find was that he had a lot of neck extension, scapular protraction, and he did have some hyperlordosis of his lumbar spine, contributing to an anterior pelvic tilt. He also had slight knee flexion on his left knee as compared to his right knee, and he had an anterior weight shift.
So we didn't notice any scoliosis of his spine from the posterior view, and the angle for his calcaneus and his calf also looked really good. So again, the scapula is a bit elevated from the posterior view, you can tell as well. And the cervical spine, we noted that it doesn't really laterally flex to accommodate for that tilt in his pectoral girdle. It seems to just kind of that he kept his head at an angle. And you can see that shift with that red line in the middle and how his head kind of leans to the side. And then again, his feet are externally rotated from the posterior view, and his left PSIS is slightly higher than the right one, whereas on the anterior side, his left anterior superior iliac spine is a little bit lower than the right side. So from that, we inferred that his left os coxa is a little bit tilted anteriorly. And then you can also notice really well from the back that his weight shift is a little bit to the right. So just to recap some main points, we noted that he has more of an anterior pelvic tilt on the left side, and then he favors his right side, which this makes sense because all of his past injuries were on that left side, so he probably compensated and now is kind of stuck with that right-sided weight-bearing shift. And then going along with that, the tilt of the pectoral girdle leans to the right, which makes sense because if he has a tilt in the left side, his spine is going to flex a little bit, and then it's just going to all lead to that tilt favoring the higher side of his pelvis. And then we notice also that his cervical spine kind of leans with the shoulder tilt. So basically the main point that we kind of wanted to get down to, we wanted to find a theory to test for our range of motion and muscle testing. So going back to how his knee was flexed on the left side, This could stem from a couple of different things. So first of all, if he has a tight gastrocnemius, that could cause a little bit of knee flexion, which in turn would potentially lead to a little bit of hip flexion in that area as well, or on that same side of the body. Or if he has a tight iliopsoas on the left, that could also cause hip flexion, therefore leading to knee flexion. So there's a couple of different ways that could go. We determined that it was more likely due to his tight psoas, and we wanted to investigate that further because a tight psoas would also correlate with an anterior tilt on that left side of his body. And then that could also cause the knee flexion that we saw. Another thing to note is that we didn't put that in the presentation, but during his gait analysis that we all watched in class, we noticed that his right heel was coming up early, but his left one looked okay. So based off of that, it doesn't seem like his gastrocnemius is too tight on the left side. So we thought we were leaning more towards a tight psoas. So basically, our theory that we wanted to test is that his iliopsoas is tight on the left side, which could be reciprocally inhibiting his gluteus maximus on the left.
So moving on to transitional movement assessment, doing an overhead squat, we are looking at different points in the kinetic chain to figure out where the need for correction is. So in doing the overhead squat, we saw that in the feet and the ankle, the tibia and the femur were in line with the second and third metatarsal, and then he also had collapsed arches and pronation, and his knees were pretty unstable throughout it. His feet remained straight throughout, but they continued to arch throughout the exercise. So then in the lateral view, we're mainly looking at his back to make sure if it's arching, to see if he's excessively leaning forward. So what we did discover is that he was excessively leaning forward in his front lean of the torso, and then his lumbar was also arching a little bit at the top. He had lumbar rounding when he would go into the down movement, butt wink, and then on top of that, he had Game Boy posture, so his arms would fall forward and his elbows were flexed throughout the position. And then lastly, his neck would extend a little bit. If you watch the video back again, we can see that his neck is more forward as he's doing the exercise. So in the posterior view, we were looking to see if the feet were flat, and if the heels rose off the floor. In this, we saw that his heels did remain on the floor, but his arches were a little bit collapsed. Also, we saw when looking at the hip, we were looking to see if there was any weight shift, and we did see that he weight shifted mainly to his right side. This is most likely due to all of the injuries that he has had have been on his left side, so his right side compensated for that. The shifts were more prominent by the third squat because he became fatigued throughout that, which can indicate left glute weakness, most likely caused from the past injuries. In the article that we showed here as cited, it was basically talking about how the presence of asymmetrical hips also indicates that weight shift.
So for our range of motion assessment, we decided to look at hip extension just based off of the static and dynamic findings in our assessments previously. For this positioning, you want your client lying supine, and then the leg that is not being measured should be pulled up into flexion, and then the leg being measured should have the knee flexed at 90 degrees, and then it's just going to be relaxed until the back comes up off the table, or if there's any other compensations such as anterior pelvic tilt, any odd other knee flexion, etc. For a normal range of motion, it's 0 to 10 degrees. The client's measured range of motion on the left was 14.9 degrees, and then on the right was 6.8. The left was a little bit decreased, most likely due to a tight psoas muscle, which we have indicated previously. For the strength assessment, we decided to look at the gluteus maximus just to see if the tight psoas was inhibiting the strength of his glutes. For this positioning, you want your client prone on a table, and then the side that is being tested should be in hip extension with the knee flexed at 90 degrees, and then the hip also abducted and slightly externally rotated.
For this strength assessment, you're going to apply slight pressure into hip adduction, internal rotation, and hip flexion all at the same time. They're meant to hold the positioning until we say to stop, basically. For the left glute, we found that there was a slight wobble through the gradual pressure, meaning that it tested at about a level 2 on the NASM rating scale. And then the right glute was pretty normal from the strength finding, so he tested a level 3 on that scale. For the left glute, we decided to retest in a slightly shortened position for the psoas, so it wasn't as extended. And once that positioning was changed, we found that he achieved a level 3 on the NASM rating scale. These are all the references that we used throughout our video. And this is a summary of the team member responsibilities.